Hi guys, today I'm going to be presenting on sodium and blood pressure. So first, just to start off with why we are even asking the question of sodium and blood pressure and the relation between them. So hypertension is a very common condition and one that can seriously impact the quality of life and health status of an individual, and too much sodium can damage blood vessels and result in high blood pressure. This is because extra sodium pulls water into the bloodstream, putting more pressure on blood vessels and forcing the heart to work harder. So over time, this strain can stiffen the blood vessels and lead to high blood pressure. Just to give you a little bit of background on sodium, I think we're all pretty aware of what sodium is in general, but just to give a little bit more granular of a look, about 30% of sodium is located in the body on the surface of bone crystals, where 70% is found in the extracellular fluid. NaCl, or table salt, accounts for the majority of sodium that we find in our diet. And the range is tightly maintained between 135 to 145 milliequivalents per liter through hormones like vasopressin, aldosterone, and atrial natriuretic hormone. Some functions of sodium are maintenance of the fluid balance, like we talked about on the previous slide, along with nerve transmission, impulse conduction, and muscle contraction. So this works in conjunction with potassium to power nerve impulses and muscle contraction, because when a nerve cell needs to communicate with another one, it opens channels that allow sodium to flood in, which tells the nerve cell to fire. And then that signal is carried from nerve cell to nerve cell until it reaches the brain or muscle for a certain action. And when triggered by nerve signals, the muscles can then alter their sodium and potassium balance as part of the process that they use to kind of contract and move. So overall, just very important for our overall well-being and body function, even just to move our muscles and to use our brain, needs sodium. So looking at deficiency and toxicity, deficiency is pretty rare, as I'm sure we're all aware, but you're thinking more like excessive sweating. So this is endurance athletes, just high-level athletes in general, somebody that's like working outside in the heat a lot, things like that. That can cause nausea, vomiting, muscle cramps, dizziness, shock, and coma. The adequate intake right now is set at 2,300 milligrams per day, but that could be switched to less than 1,500 milligrams per day based on some new upcoming research. But right now it is the 2,300 milligrams per day. And the toxicity is intakes over 2,300 milligrams. There's not like a certain threshold necessarily where it becomes toxic versus not toxic, as with some other vitamins and minerals, but it's just kind of more of a gradual thing. So the higher in sodium that you get, the more kidney damage, high blood pressure, fluid overload, and cardiovascular issues that you would see. So it's more progressive rather than a sort of like hard and fast rule. Some sodium sources. It's really hard to narrow down the sources of sodium. It's in a lot of things, but here are just some common examples. So soy sauce, milk, breads, biscuits, muffins, canned beans, vegetables, processed foods. That processed foods accounts for 75% of total sodium consumed. And it's also important to note that sodium content fluctuates depending on how much something is processed. So I think the breads example is a great one to look at. Like if you're making bread at home, that is not going to have as much sodium in it as if you're getting like a processed biscuit from a can or something like that, which both of those are amazing and taste great. But if you're eating, these processed foods more often than not, it's definitely a little bit more of a risk in terms of your overall sodium intake and how high that can get. So now looking at the DASH diet, this is a diet that is lower in sodium in hopes of interacting with the renin-angiotensin-aldosterone system to promote the vascular and hormonal responses to induce a hypotensive effect of lowering sodium intake. And so we can see kind of along the bottom of the screen and the right side the components of the DASH diet eating plan. So focusing on eating vegetables, fruits, whole grains, fat-free or low-fat dairy, fish, poultry, beans, nuts and seeds, vegetable oils, and then limiting fatty meats, full-fat dairy, sugar-sweetened beverages, sweets, and obviously sodium intake. So this diet is low in saturated and trans fats, and rich in potassium, calcium, magnesium, fiber, and protein. Obviously lower in sodium. So just overall, a generally healthy diet, kind of similar to the Mediterranean diet, but focusing specifically on decreasing sodium to at least 2,300 milligrams per day, if not lower. So to get into the systematic review that I chose, it is titled Dietary Approaches to Stop Hypertension, or the DASH diet, and blood pressure reduction in adults with and without hypertension, a systematic review and meta-analysis of randomized controlled trials. So just to give background on the current research, or why I choose this question, hypertension is one of the most significant causes of morbidity and mortality worldwide, because that elevated blood pressure can influence cardiovascular and renal issues, which we know are very serious and can be very deadly. And sodium and potassium, but also different dietary patterns such as the DASH diet, are associated with blood pressure reduction. The current management of hypertension is lifestyle modifications like this kind of diet, but also underlying drug treatment as well. But I think it's cool to note that the effect of the DASH diet, which was first noted over 20 years ago, does have a pretty big effect on blood pressure and can be more of like a natural alternative to some of those drug treatments if people are interested in that. And they can also definitely be used in complement with each other. Just because, you are on antihypertensive treatment does not mean that you shouldn't adhere to the DASH diet too. Overall, it's just rich in fruits, vegetables, and low-fat dairy. And the objectives of this current study were that current clinical trials vary in study design, dietary protocol, and patient characteristics, which can then impact the achieved blood pressure reduction or just the measurement or results of the study. Methodological and clinical differences like sodium or energy restriction or hypertension patients compared with normotensive patients can just really differentiate this reduction. So they wanted to do an overall review of the literature to estimate the effect of the DASH diet compared with control diets on the attained BP reduction, independent of the baseline blood pressure of the individual, by considering all available RCTs in hypertensive and non-hypertensive adults and accounting for the underlying methodological and clinical confounders that were not previously considered. So to get into the methods of the study, RCT is comparing the DASH diet versus control diet on blood pressure levels were included, irrespective of accompanying comorbidities like metabolic syndrome, diabetes, obesity, and also they were included whether they reported blood pressure changes as primary or secondary outcomes in the study. And then the DASH diet in combination with other lifestyles, such as like a sodium restriction, which is in the DASH diet, but say it's like a specific type of sodium restriction or level of sodium restriction. Weight loss or physical exercise were also included. Lastly, studies that were evaluated for potentially overlapping populations. If that was the case, then the study with the largest sample size in that population, that publication was chosen to be included in this study. In terms of exclusion criteria, non-randomized trials, studies with no control group, studies not reporting outcomes about blood pressure, studies with internet-based interventions, and studies conducted in children, adolescents, or pregnant women were not included. And then also RCTs between the DASH diet and other DASH-like diets that are not the official DASH diet were also not included. Continuing on with the methods, 2 independent reviewers performed a systematic lit search in the Medline and Cochrane collaboration library databases using RCTs up until February 28th of 2019. They found these using the PICO approach, which is problem, intervention, comparison, and outcomes. The problem was identified as hypertension. Intervention was the DASH diet compared to the control diet. And then outcomes were attained SBP and DBP reduction, so systolic blood pressure and diastolic blood pressure. I'll continue to refer to them with the abbreviations, but that's what they mean, just for reference. And then references of included studies and previous meta-analysis were used to identify potentially missed articles as well. So a well-rounded identification of studies. Getting into their selection, the titles and abstracts of the studies were screened by 2 independent reviewers, and then the full text of the studies that met the inclusion criteria were independently assessed for eligibility. Pre-piloted standardized form was used to extract data from the included studies by each reviewer independently, and any agreement or disagreement was discussed and resolved. So the information extracted from all of the trials was publication details, like the author's name, journal, year of publication, study characteristics of the participants, the study design, the implemented data analysis, the quality of the study, the dropout rate, the weight change at the follow-up, and dietary adherence as well. The follow-up period, how long it was since the end of the study, or since the end of the trial until the follow-up of the individual, and then the baseline mean blood pressures and the attained mean blood pressures, so starting off versus ending blood pressures, and then the attained difference in mean, and then changes in 24-hour urine excretion of sodium as well. To gauge bias, the reviewers assessed the risk of bias and included studies through the Cochrane Collaboration Risk of Bias tool for RCTs. It was reported as high, low, or unclear risk, and 2 high or unclear risk of bias elements or more created the lower quality label for the study. Each was rated independently using the grade approach. Grading of recommendations, assessment, development, and evaluation. And it was investigated by funnel plots and by Eggers and Beggs test, and a p-value of 0.05 or less was considered statistically significant. So now getting into some statistical analysis, they used Comprehensive Meta-Analysis version 3, and outcome variables were pooled as mean differences with 95% confidence intervals. A standard deviation of blood pressure is from the individual standard deviation of the 2 randomized arms. And if no significant heterogeneity was found, they used a fixed effects model. Otherwise, a random effects model was used. To test the influence of individual RCTs on the total effect size, they excluded 1 trial at a time, and if the point estimate of the total effect size was outside of the 95% confidence interval for BP with that trial excluded, that trial was considered to have excessive influence over the results of the study. They also did subgroup analysis, where clinical characteristics of participants and study design variables were conducted, and then univariate and multivariate meta-regression analysis, especially meta-regression analysis, was used to determine whether a modulating effect of clinical variables remained significant. Getting into results, this first figure shows study selection and study characteristics. You can see kind of how they narrowed down the studies. They started with about 576 studies through database searching, and additional records were identified through other sources, 3 studies from there. After the duplicates were removed, they were down to 400 total and records screened. And so 326 studies were excluded based on title or abstract. 74 full-text articles were assessed for eligibility, and then 30 of those were included. The total number of participants is 5,545. 45% of those participants were men, mean age of 51, and mean BMI of 29.2. Mean baseline blood pressure was 134.3 over 84.9, and the mean follow-up length of time was 15 weeks. Figure 2 shows the effects of the DASH diet on blood pressure levels. So the mean difference for systolic blood pressure was a negative 3.2. The 95% confidence interval was negative 4.2 to negative 2.3 with a p-value of 0.001. And diastolic blood pressure was negative 2.5 with the confidence interval being negative 3.5 to negative 1.5. And again, p-value of 0.001. Less than 0.001, excuse me. And no trial demonstrated excessive influence over the results of the studies. And higher quality studies, we still didn't see an intervention effect of blood pressure changing. So whether the quality of the study did not determine if the intervention effect of blood pressure was noticed or not. Figure 3 is the role of hypertension, antihypertensive drug treatment, and baseline blood pressure levels on the effectiveness of the DASH diet. 10 trials/subgroups of trials included patients without hypertension, and 16 trials and subgroups of trials included only patients with hypertension. Both observed blood pressure reductions, and the heterogeneity did not differ. Trials and subgroups with hypertension and no antihypertension treatment did see a mean blood pressure reduction that was higher than for hypertension patients that were on treatment, which we'll see in that next bullet. Trials and subgroups with hypertension and antihypertension treatment still did see a reduction in blood pressure, but it did not reach statistical significance. So again, just showing that these things are meant to be used in complement with each other. It doesn't necessarily need to be one or the other, but even if you are on active antihypertension treatment, you could still see a reduction in your baseline blood pressure from adhering to the DASH diet. And additionally, the DASH diet blood pressure lowering effect does not depend on a higher or lower baseline blood pressure. Table 2 shows subgroup and meta-regression analysis by relevant variables. So they first did dichotomous variables and found that the DASH diet effect was more pronounced in trials and subgroups with sodium intakes above 2,400 milligrams per day and trials with a mean age of less than 50 years. They tested other things, but these were the ones that they found the DASH diet effect more pronounced in. So, and that makes sense. Trials and subgroups, if you, with sodium intakes higher than 2,400 milligrams per day, if you're having, let's say 4,000 milligrams of sodium per day versus somebody having 2,500 milligrams of sodium per day, and you're following the DASH diet, you probably are going to see a bigger reduction in blood pressure with those individuals that have higher sodium intakes on average per day. And then also mean age of less than 50 years just can be because there's other factors as we age that increase blood pressure that might be kind of irrespective of the DASH diet or not targeted by the DASH diet. So it was found to be more effective in trials with a lower mean age. And then they also tested this with continuous variables. And as age increased, the DASH diet effect on lowering blood pressure decreased, specifically systolic blood pressure, which again makes sense. But the other factors they tested, like BMI, baseline blood pressure, duration of follow-up, etc., did not have a modifying effect on blood pressure reduction. And then lastly, they ran multivariate meta-regression analysis and showed that among certain effect modifiers like baseline blood pressure, age, sex, BMI, duration of follow-up, all that kind of stuff, the longer adherence to the DASH diet, the greater the reduction in blood pressure. So just to discuss, the DASH diet results in significant systolic blood pressure and diastolic blood pressure reduction, which is independent of baseline blood pressure levels. The extent of blood pressure reduction was actually higher in hypertension patients without underlying treatment than in all hypertensive patients, just overall as baseline. Higher amounts of baseline daily sodium intake enhance the blood pressure lowering effects of the DASH diet. Again, makes sense, just because the DASH diet is going to be more extreme lowering for patients that are consuming more extreme high amounts of sodium. And age may be an inverse modulator of DASH diet effects on blood pressure reduction. So overall, results are supportive of the DASH diet. Some limitations: 50% of the studies had over 2 of those elements scored as high or unclear risk of bias, which is likely due to the unblinded nature of some of the RCTs included. So the Hawthorne effect at the participant level might have been increased as compared to blinded studies. Measurement of office BP, this was at follow-up, was problematic or unclear in selected trials. No subgroup analysis was attempted by sex due to limited data and lack of statistical power. So that would definitely be a factor to consider and potentially look more into. The mean follow-up was 15 weeks, so we're unsure of long-term effect. And DASH and control diets were not identical in terms of macro and micronutrient content. Some implications for future research: definitely want to find some studies with blinded participants and researchers, and also compare the general diet versus DASH diet, equivalent in macro and micronutrients, obviously excluding sodium, because that's what you're kind of testing on, and but in terms of all the other macro and micronutrients, trying to make those as similar as possible just to weed out any confounding variables. And also interested to see the long-term impacts of the DASH diet. We already saw evidence from this study showing that longer-term adherence leads to even greater blood pressure reduction, but obviously it would be interesting to know if that has a cap on it, if there's a certain amount of time that's the best to stick to it, or just more information about the long-term impacts overall. Some implications for dietetics and nutrition. This does support the DASH diet implementation, and it encourages dietitians and healthcare team members to continue recommending the DASH diet to patients with hypertension. And then here are my references. Thank you guys so much for listening.